asking questions that I think a lot of patients have on their mind, and I can just address them. Does that sound okay?
Yeah, that sounds great. All right. So yeah, we are recording. And so welcome, Dr. Rad. Thanks for chatting with us tonight in the Breast Friends DC community. We're really glad that you've taken the time out of your busy schedule to be with us.
Oh, well, it's an absolute pleasure, because not only is it you, Denise, who I'm speaking with, and I'm always happy to chat with you, but you know, you're on a mission that's so important globally, not just in this country or in this area, but globally, the mission to educate women about their options for breast reconstruction and how to get their bodies and their emotional well-being and everything kind of back on track in a very positive way after a difficult chapter of breast cancer treatment. And there's just so much information, a lot of which is very confusing.
Yeah.
So I share that mission with you, and good on you, Denise. I mean, you're such a pillar of strength for so many women, and you know, I hope I can give some clarity with this conversation.
Well, thank you. Thank you. And for our Breast Friends community, Dr. Rad is my doctor, and that's how he knows a little bit about me. And I can attest to your compassion and the way that you so elegantly and yet almost simply distilled such complex information for me right after I was diagnosed and very emotional. And you gave me confidence from those first few words of telling me that just everything was going to be okay. So you really do a great job of, right at the very beginning of the appointment, sincerely understanding that people don't want to necessarily be sitting in that seat. If we had a choice and we wanted to pick and change something about our body that wasn't cancer related, that's a whole different situation. And I think I would definitely be equally as confident with you, but knowing that you have cancer in your body and you're part of the team to remove that, you handle that so well. And I just can't thank you enough for that. And so I would love for you to share a little bit about the options that sort of you walked through with me when I had to decide, when I had to decide on my mastectomy, which way that I should go. And I'll let you walk through them. You say it much more expertly than me.
Well, I so appreciate your kind words, Denise. And it's so difficult being in that chair for the first time, consulting with so many surgeons and oncologists and, you know, care providers, where it feels like you're being sucked into a vacuum and you don't know where you're going to end up at the end of it all. And, you know, I tell every patient who sits in my chair, I said, everything's going to be fine because you're in the right circle of care.
Yeah.
You know, and that is such an important thing, to rest assured that everyone is devoted to getting each patient through safely, effectively on the other side, and onto a brighter chapter of their lives with all this in the rearview mirror. And sometimes it's very daunting to think that that light at the end of the tunnel actually exists, but it does.
Right. Yeah.
It really does, because in the right circle of care, the physicians and caregivers involved in patients' care, you know, have been through this with hundreds, thousands of patients, and you know, it's your first time as a patient. And so I don't take that lightly. It's so difficult, you know, to make sense of it all.
Right.
And so to your question about walking through the options, let's dive into that and really kind of try to understand that.
Yeah.
Breast reconstruction, first of all, has been proven to improve patients' quality of life. That's been proven by scientific study, actually published literature proving that women's emotional states and states of well-being are enhanced after successful reconstructive surgery. And what do we mean by reconstruction? Well, restoring what was lost, right? That's the point of reconstruction, is giving women back what was taken away as a result of breast cancer treatment. So mastectomy, you know, everybody's kind of familiar with that concept, and certainly you know, patients who are facing mastectomy watching this video know full well that it's a pretty significant surgery and it can be quite deforming. So in my mind, whenever I'm consulting with a patient, I'm always thinking of the end goal in mind, with 3 specific principles that guide me. Okay, so 3 specific principles that always guide me with every single patient. One, I want to achieve the end result that the patient has in mind. So, and I tell people, you know, your happiness is what I'm interested in, not my happiness. I want you, the patient, to be happy and thrilled with your result. And everybody's a little bit different in what they want in the end of the whole process of reconstruction. Some patients, they just want their, you know, the breasts exactly how they looked or as close to what they looked like before their cancer surgery. Others, you know, want a little enhancement, or others want a little, you know, bit smaller breasts. Some want very specific, you know, fullness at the top and a bit better definition here and there. You know, view this as an opportunity to get the result, get the vision that, you know, you might have always had, or, you know, use this as an opportunity to hopefully get a better result, look better in the end. You know, I don't just try to restore what was lost, but I try to give patients, you know, a result that will make them feel like they look even more beautiful or more confident, where they can just forget about all the cancer treatment and just, you know, be thrilled with their results. So getting a result that patients want and doing it safely. So safety is the most important thing, of course, right? Getting from the start of the whole process to the end with as high degree of safety as possible. No one can ever argue with that, but I'll tell you, you know, there are a lot of safety details that I think are just so critical for the surgeon to keep in mind and to communicate with patients. And then doing so with the least amount of surgery to get there, right? Because surgery involves downsides of recovery time, you know, discomfort, pain, bruising, swelling, taking time off work, not being as active, you know, from the standpoint of exercise and all those sorts of things. So we want to minimize those downsides of surgery. I haven't gotten to the options yet, but I just wanted to give sort of a bird's eye view of how I think and approach every patient's surgery with those three things in mind.
Right. Yeah. I mean, I know that you covered those with me, and I know one of my big things was I just wanted to get back to the gym so I could feel a sense of normalcy.
Right. And that's so, yeah.
Yeah.
Everybody has a bit different priorities, and that was a high priority for you. So, you know, working with you and working with every patient of mine to focus on their priorities, like you said, getting back to exercise in the gym. Other people, they just want to get back to, you know, taking care of their family or get back to their work quickly. Others have kind of a long-term view in mind where they say, you know what, I want to minimize the chance that I'm ever going to have surgery again.
Sure.
And so I want to take that long-term view, and I know it's a little bit more upfront, but, you know, that's where the choosing what the best path is can be a bit daunting.
Yes,
when you
I
have
know.
choice. Okay. Now choice opens up, you know, there are pros and cons. Choice opens up a whole array of options that, on one side, it's excellent. It's great that you can have a choice, because oftentimes in cancer treatment, you don't have a choice. Like, okay, you need chemo, you need radiation, you need surgery. There's, you know, you need a mastectomy. There's no option for some women. Whereas for others, you know, there's more choice involved. And for reconstruction, I want patients to feel like they are in control. They have power to choose what path is best for them. Empowering women is such a critical thing in breast cancer care and breast reconstructive care, because oftentimes with the cancer treatment, there is not much of a choice. It's like you have one path and you got to take it to get the best possible prognosis. But on the reconstructive side, there are a lot of different options, but that can be confusing too. So I'm happy to jump into the
overwhelming.
Yeah, it can be overwhelming. Exactly. So I try to break down very simply for patients to think of two pathways. So think of coming to a fork in the road, you know. One path is with implants, okay, silicone implants. The other path is using one's own tissue. And I'll expound on that because the topic of our conversation, Denise, we're planning to talk about tissue options.
Yeah.
And feel free to interrupt me, Denise, because oftentimes I get on a monologue because I get excited.
No, it's all very helpful for our audience. Yeah.
Yeah. So two paths, either implants or tissue. So what do I mean by tissue? Well, that's involves transferring tissue, fat in particular, skin and fatty tissue, from one area of the body where we might have some extra. So for example, the belly area is a very common, for me, a common area to borrow from. Not common in general, because very few plastic surgeons offer this tissue transfer option, but it's a common surgery called the DIEP flap, DIEP. It stands for a very complicated name. But the point is, you get a tummy tuck, you get an abdominal contour improvement, and instead of throwing away that fatty tissue that might be hanging down or is, sort of extra there, and who doesn't want a flatter tummy? I can repurpose that, take that fatty tissue and sculpt it into the form of a breast, transplant it to rebuild a woman's breasts. And it's a very powerful technique because it solves many, many problems that can occur with implants. So implants are the more simple ways to do reconstruction. And a silicone implant, I don't have one here, but a silicone implant is human-made, manufactured implant that is good for certain types of bodies and certain goals.
Sure.
And it's definitely an important option for women to be aware of, but there are limitations of implants.
Yes.
There are some issues that can be associated with implants. Scar tissue, for example, tightening around the implant that can lead to further surgery. Implants are not considered to be lifetime devices according to the FDA, right? Our national safety governing body. The FDA says it's not a lifetime device, meaning that all women who have implants will eventually need some sort of surgery to correct an issue with the implant. So I won't go into the details of those downsides of implants, but suffice to say that tissue completely solves the downsides and limitations of implants. Tissue solves problems. Why? Because it's your own tissue. It has its own blood flow. When there's a healthy blood flow through your own tissue, then that really has a healing effect. It's like using the body to heal the body. It's a very powerful concept. Does that make sense?
Yes, yes. And I think, eventually I would love to talk to our audience more about the implants and the things that, you talked about on that side. But yes, having your own body be a part of a new part of your body someplace else is very refreshing almost to think about. And so I don't know how much time you have left, but is that, and it's also, you also move the veins, right? So you move some veins back from someplace to someplace.
Yeah, right. Yeah. So let's zero in on the DIEP flap technique, the technique that I mentioned about transplanting abdominal fatty tissue. So, if you took your hands and you pinched your lower belly tissue, right, below the belly.
I have that since COVID.
Right. COVID weight. I mean, we can say goodbye to COVID weight because we can for a better purpose. So if you're pinching that lower abdominal tissue, that fatty tissue that might be hanging a bit, and even for slender women, there's, oftentimes we have some pinchable fatty tissue there. That's the tissue that I transfer by basically kind of disconnecting it from the body. And then I reconnect it in the breast area by, just as you said, Denise, transferring veins as well as arteries. What I do is basically hook up these tiny little blood vessels, veins and arteries together to restore circulation through that tissue that I've transferred, through the abdominal fatty tissue. And that step is called microsurgery, microscopic surgery, because it's surgery under a microscope. The reason it's under a microscope is because those little blood vessels are very small. So think of it like plumbing, you got one pipe coming into another pipe and you hook them together to restore flow through the pipe to deliver blood and oxygen to the tissue that's transplanted. That is a very delicate operation that only a handful of plastic surgeons really have the skill and expertise and experience to do it effectively and successfully. So in the right hands and very experienced hands, in the hands of plastic surgeons who do this surgery many, many times, and I've done well over 1,500 of these tissue transfer operations for breast reconstruction, the success rate should be about 99% or greater. National average is about 96 to 97%, so pretty good, right? So 96, 97% of the time it's successful, 3 to 4% of the time the transfer doesn't work, which is not dangerous to the patient's health, but that's the point of the surgery. And I'm very proud that my success rate is over 99%, so 0.8%. So 8 out of 1,000 times we have an issue with blood flow through the tissue. And as much as I want that to be 100%, nothing in life is ever 100% or 0%, but just, be reassured that this is a very safe surgery involving very, very low risk, highly effective to solve many, many problems and give patients a lifelong result, right? Isn't that wonderful? A result that lasts their entire lives.
Yeah.
And so they don't have to ever see me again.
Oh, no. So I think for now you've given such a great overview of these two options, the breast implants, silicone, you use the silicone breast implants, not the textured that we've heard about in the news, not that, you use the other. And then this deep flap surgery, which I do want to talk to our audience more about, because I know that there's other options of taking the fat and tissue from the love handles and other areas in the body. So I think that I would love to have you back to talk about what recovery is like for deep flap, and or could you talk more about these other types of surgeries too, or if you had a minute to review them now, it's up to you. Sure. I know you're so busy and
it's all good.
We need to get back to your family.
No, we're all good. We're all good. So yeah, the deep flap is the first go-to selection. If you think head to toe, what are the areas of the body where we have, where women have some extra fat to potentially donate? So the lower abdominal region is the first choice.
Yeah.
Because restoring a woman's breasts to the proper shape and size, fullness, and symmetry, all those important details can be achieved with a deep flap. And so it's always my number one go-to tissue transfer operation. Number 2 and number 3 options come from the love handle area. Mm-hmm. So it's not the butt and it's not the flank. The flank is, just to the side of the belly, right? So it's just like right here. This is the belly here, the flank's here. It's just behind that. So like right here, the love handle flap, it's called the SGAP, SGAP. It stands for a long name as well, but I think it is the love handle flap. And actually we pioneered this when I was on full-time faculty at Johns Hopkins, where I did my training, and then I was on the faculty. We pioneered this technique of taking love handle fat and transplanting that with my colleagues there, Gedge Ross and Jaime Flores, phenomenal surgeons. Dr. Rawson is up in Baltimore at Johns Hopkins. Dr. Flores is down in Miami. Incredibly talented people. Look them up if that's something you'd be interested in for tissue reconstruction. And so taking love handle, nobody loves their love handles, right? So we can do an improvement to the love handle area for people who don't have a lot of belly fat. Yes. Or who have had, prior surgery on their abdomen. Sometimes we can't do the deep
C-section or something.
Yeah, well, C-section actually we can do. Generally can do it, yeah. And you think of moms who get breast cancer, it just restoring their bodies to their pre-pregnancy abdominal shape, like a mommy makeover.
Very empowering.
Right. Yeah, it's like a win-win. So the deep flap is great, but the backup is the love handle. And then the inner thigh is the third backup.
Oh, okay.
The inner thigh, the upper inner thigh. So think of the upper inner thigh as taking that tissue. If you just kind of pinch the upper inner thigh where your groin is, right, the groin area. Oftentimes women have a little extra pinchable fat there. The downsides of that is that it doesn't get a lot of volume, but it can be a very good second or third option if the deep flap is not available. So the key thing is just being in the hands of a surgeon who can offer this spectrum of tissue options. And I'll say about 1% of plastic surgeons can offer these sorts of microsurgery transfer procedures, because it's just it requires a certain team and a certain skill set and a certain doing it many, many times.
And you help the patient help them with these options by just talking with them. And I can attest to that because I had to try to figure that out myself and which way to go. And you were just so great in helping me through that decision. And that wasn't something I could really make overnight. It took me a few days and talking to a couple of other patients. That's why we created this community, because we wanted to pay it forward for others that helped me and my partner, Nura. She helped me, and then my college roommate, Annie, helped me too. And then hearing their experiences in they had different scenarios than I did, but you really helped me figure out, which route to go. And so I assume you do that with all patients. You did that with me, right?
Of course, yeah. Every patient is unique.
Yep.
Every woman has a unique situation. There's no cookie cutter. Surgery should never be cookie cutter, right? Where one size fits all. That's not how surgery works. It's very tailored, very customized, very specific to a woman's, not only her body and her anatomy and what the surgeon might think, oh, this would be the better option, but being sensitive to what a woman needs.
Yeah.
And what her needs are, because she may not be, she may have reservations about a DIEP flap or, one of these surgeries, because it is more complex and involves more recovery than implant surgery. Implants have the advantage of being pretty straightforward, simple, predictable, outpatient surgery, but with those long-term downsides.
Right.
Right. Tissue reconstruction, on the other hand, actually has been proven scientifically that the long-term advantages, I'm talking over, years and decades of a woman's life, far outweigh the downsides of the DIEP flap surgery and far outweigh the short-term upsides of implants. So in the long term, tissue reconstruction really makes people happy. That's been proven, it's been studied and published.
Wow.
So, it's oftentimes it's a bit challenging when you're facing a cancer diagnosis and, you got surgery to face, you got chemotherapy, maybe radiation, lymph nodes taken out. I mean, there's a lot of stuff thrown at you.
Yes.
And so the last thing that, some people want to think is like, I got to have more than one surgery to get the reconstruction. I just want to get to the finish line because I just want to get back to my life. I want to get back to my family. And that's okay, because tissue options will always be there.
Right.
If you're a good candidate from the beginning, you'll be a good candidate later.
Yeah.
Start with an implant. But I do want to emphasize that DIEP flap surgery is not nearly as daunting as what people hear on the internet or from other people's experiences in the right hands. And when I say the right hands, I'm not talking just about the surgeon. I'm talking about the team involved, including nurses, the OR team. They have to, the team has to be so experienced to know all the steps involved to be like a well-oiled machine.
Wow.
Right?
Yeah.
And that's what we have at Fairfax Hospital. I work with the best of the best. And in many ways, it's just as good as Johns Hopkins, where I spent 10 years of my training and then on faculty. In many ways, the care for DIEP flap surgery and microsurgery is as good as it is at Johns Hopkins, the world's top institution. Because we've just refined every little detail to get patients through very safely and effectively with minimal downtime. And I have patients walking out of the hospital on day 2 or day 3 after surgery, not on any narcotic pain medicines.
Wow.
I mean,
that seems just so incredible.
Which is awesome, because it used to be that patients would be in pain for weeks on narcotics and they can't get back to their work, they're driving, they get sort of foggy brain from the narcotics, et cetera. We've mastered pain control with the ARIS protocol. Maybe that's a topic for a future segment.
Yeah,
ARIS protocol is enhanced recovery after surgery. You can Google search, your viewers can Google search it. Enhanced recovery after surgery protocol, ARIS, developed by anesthesiologists to combat the opioid epidemic. We've leveraged that power to get patients through with minimal pain, and it works so well. And the key ingredient is Exparel, which is an injected numbing medicine that numbs the area, local control of pain, so you don't have to be popping pills all day and be knocked out, right? So recovery is a matter of days, 7 to 10, maybe 14 days to feel pretty good. Now, you're not running marathons, but feeling pretty good after a couple of weeks. And it's not like the 8 to 12 weeks that people used to think of, when thinking of DIEP flap. So huge world of difference. So I encourage people not to be scared by this, in the right circle of care, in the right hands. Anyway.
Wow.
I'm getting on my monologue again.
As you were talking, I was thinking about just all these decisions that women have to make, and there's such a big ecosystem, or maybe that's the wrong word, just a universe of decisions, and then there's the decision tree after that. If I go this way, then short term the results might be maybe easier, then long term it won't be.
Oh my gosh, my lights fell off.
You
Right.
know, or, you know, in the other case, it's a little bit longer. So, you know, I appreciate you walking us through all of these different options. And I am really grateful for the time that you spent with me tonight and with our audience. And Nora also appreciates everything that you're doing with us. And we really would love to have you back for another session. Yeah. And then maybe I can even talk about my personal experiences on which way that I went and where I am with my whole journey. So,
you know, it's always so wonderful to hear patients, you know, tell their own stories, because it takes such strength to do that, Denise. And you've been such a pillar of strength. I mean, you're showing it just with your mission, with, you know, your new website. Congratulations launching that.
Thank you.
You know, all the information you're putting out there to give women the power, empowering women with, you know, with information. And, you know, you're walking, you walk the walk, right? You don't just talk the talk, you walk the walk. You are a patient, gone through challenging times. So what better experience than, you know, sharing that one? So.
Well, thank you. Thank you so much. I really appreciate it. And I hope you have a good evening and we get you out to your family on time.
That's all.
Thank you so much.
With you, Denise. And,
all right. Cheers. Bye-bye.
Take care. Bye-bye.